Good morning, all of you. Today we are late due to a technical issue. Okay, so today's topic is primary open angle glaucoma, which is again an important topic for your long question. So, first of all, we need to know what is glaucoma. So, I hope all of you must be knowing it. So basically glaucoma is a group of eye disease which result in the damage to the optic nerve and can cause a permanent visual loss, right? So the most common type of glaucoma is primary open angle glaucoma, which we'll be discussing today, right? So we'll be discussing about primary open angle glaucoma. Okay, so primary open angle glaucoma is also referred to as chronic simple glaucoma and is generally a bilateral condition, okay, and not always symmetrical, and it is basically characterized by an adult onset, and the intraocular pressure is usually more than 21 mm of Hg, and an open angle glaucoma usually have a normal appearance. So the characteristic feature is optic disc cupping and visual field loss. Okay, so these are the risk factors. So when we come to the risk factors, so first we have the intraocular pressure, which is again the most important risk factor. Then we have is the age. So it's normally, in most of the cases, it is seen in 40 years and above. And race, we have blacks more than the whites. And obviously family history and siblings are more often seen rather than offsprings. Then we have diabetes mellitus. We have a reduction in perfusion pressure. Myopia is also again a risk factor for primary open angle glaucoma. Then we have the retinal diseases like CRVO, central retinal vein occlusion. We have RD, which is retinal detachment. Then we have RP also, retinitis pigmentosa. And a few risk factors are related to the thyroid disorders, smoking, and steroid use, right? So more than 6 weeks if you chronically use steroids, systemic and topical both. So they are again risk factors for glaucoma, right? Another thing is we have to come to the pathogenesis of the increase in the intraocular pressure. So basically the rise in intraocular pressure occurs due to the decrease of the aqueous outflow. So the reduced aqueous outflow facility occurs due to failure of the aqueous outflow pump mechanism. Okay, so this is basically related to the increase in the intraocular pressure. So there are various theories that can coexist, like in the etiology. So you need to understand the most important risk factor for glaucoma is increased intraocular pressure, and intraocular pressure is a function of production of the aqueous humor, and aqueous humor is basically the function of the production of the aqueous humor by ciliary process. So it is usually done by the ciliary process of the eyes, and its drainage is through the trabecular meshwork. So the aqueous humor flows from the ciliary process into the posterior chamber. So that is basically bounded by posteriorly by the lens and the zonules of Zinn, and anteriorly by the iris. So it is then it flows through the pupil of the iris into the anterior chamber, bounded posteriorly by iris and anteriorly by the cornea. So from here the trabecular meshwork drains the aqueous humor via the scleral sinuses, which we call as a Sclem's canal, into the scleral plexus, and then it goes to the blood circulation. So you need to understand this, the pathogenesis of the increase in the intraocular pressure. So I repeat once again, the intraocular pressure is basically a function of the production of the aqueous humor by the ciliary processes of the eye and its drainage to the trabecular meshwork. So what happens is the aqueous humor flows from ciliary processes into the anterior chamber, bounded by the lens and the zonules of Zinn, and anteriorly by the iris. So it then flows through the pupil into the anterior chamber, and bounded by iris and anteriorly by the cornea. So from here it goes to the trabecular meshwork via the Sclem's canal, and then the general blood circulations occur. So the reduced aqueous outflow facility occurs due to failure of aqueous outflow pump mechanism. So this happens like there's thickening and sclerosis of the trabecular meshwork, there's narrowing of the intertrabecular spaces, and the deposition of the amorphous material in the juxtacanacular space, and collapse of the Schlem canals, right? So these are the pathogenesis. Okay, so the epidemiology of primary open angle glaucoma, it usually affects about 1 in 100 of the general population above the age of 40, which I have already told you, and forms about 1/3 cases of all the glaucomas. So this is the prevalence, you can see 1:1, 1:2, 1:3, 5:1. So in Indian it's 1:1, urban Chinese 1:2, and Mongolians it's 1:3, and European Africans it's 5:1. So these are the prevalence of primary open angle glaucoma as compared to the other one. Now we come to the clinical features. So in clinical features we have is the first we come to the symptoms. So the symptoms, most important is it's a gradual painless loss of vision. So you need to understand about the signs and symptoms, right? So primary open angular glaucoma is a painless condition, and it does not have any acute attacks. So thus the lack of the clear symptoms make the screening via the regular eye checkup. So we need to regular monitor the eye, the intraocular pressure, the visual field, and the optic disc changes. So you need to remember that the signs and symptoms, basically it is a gradual painless loss of vision. With that you can have a mild headache, you can have an eye ache, then you can have a visual field defect, which is a scotoma. Then there is frequent change in the presbyopic glasses, that means the near vision is hampered, right? Then we have the delayed dark adaptation, then we have the significant loss of vision and blindness. These are the signs and symptoms, right, of primary open angle glaucoma. So the most important is it is the gradual painless loss of vision. And you need to remember 3 things in glaucoma, like you need to have an increase in the intraocular pressure, then there has to be optic disc cupping, right, and third is the visual field defect. So these 3 things, if any patient has any of the 2 criteria, then we can label them as a glaucoma. If he's having any 1 criteria, then we can label him as a glaucoma suspect, and we can do regular checkup of the visual field of the intraocular pressure and optic disc also, right? Okay, so there are some signs which we can see in the primary open angle glaucoma. So the anterior segment signs is the corneal haze. Sometimes we have the sluggish pupil, the intraocular pressure changes. So we have repeated observation of the IOP every 3 to 4 hours, which is known as diurnal variation test. So it is generally done in the patients of glaucoma. Then we have the different patterns of the diurnal variation by IOP. Morning rise of IOP is 20% cases, afternoon 25%, biphasic rise 55% of cases, right? So any variation of IOP over 5 mmHg is suspicious, and over 8 mmHg is diagnostic of glaucoma. So this is a very important thing, which is is usually it is done with the shears, but nowadays we are using the applanation, which is more accurate. Okay, so this is the optic nerve head evaluation. So the normal optic nerve head, as you can see, the 2 circles. So the small one is the cup and the large one is the disc. So the ratio, which we call is the cup disc ratio, and the distance between the 2 is the neuroretinal rim, right? So this is the tissue between the outer edge of the cup and the disc margin. So the normal rim is generally it is orange or pink in color, right? And there isn't rule, which will come to later, and there is rim disc ratio, cup disc ratio. So the normal CD ratio which is 0.1 to zero point 0.4. So in glaucoma it increases, like it becomes 0.5, 0.6 or zero point 0.7. So then we have a suspicious thing that the patient can have glaucoma. So when it is beyond zero point 0.3, so sometimes it can be physiological cupping also, but if IOP is raised, if IOP is raised with with the cupping, then there's a thing that we need to do a perimetry for the visual field to confirm or diagnosis whether the patient is really having glaucoma or not. Okay. So this again I was talking about is a small one, you can see is the cup, and the outer one is the disc, right? So the CD ratio is generally 0.3, and the space between the two, the edge and the cup, is the neuroretinal rim, right? So this again you can see the fundus picture having slight cupping of the disc. Okay, so now we come to the early glaucomatous changes. So as you can see in the picture, of the picture D, so you can see it's slightly enlarged. So the CD ratio is it's between 0.5 and 0.6 according to the image. So it is glaucoma suspecting. So early glaucomatous changes include vertically oval large cup, right? So which you can see in the picture. So the asymmetry of 0.2 between two eyes, large cup which is 0.6 or more. So the normal cup size is 0.3 to 0.4. Then we have the pallor of the disc, we have the splinter hemorrhages, we have the atrophy of the retinal nerve fiber layer. Okay, so these are the early glaucomatous changes. In advanced glaucomatous changes, we have more cupping, so the cup size increases from 0.7 to 0.9. Then we have the thinning of the neuroretinal rim. Then we have the nasal shifting of the retinal vessels, which is also known as bayoneting sign. Then we have the pulsation of the retinal arterioles. Then we have the lamellar dot sign. So this you need to know key in advanced glaucomatous changes. So the most important thing is the cup disc ratio, so it becomes 0.7 to 0.9. okay, and the thinning of the neuroretinal rim and the nasal shifting of the retinal vessels, which the three you can see when you dilate the fundus. Okay, so next is glaucomatous optic atrophy. So all the neural tissue of the disc is destroyed and the optic nerve head appears white and deeply excavated. So this is the condition, this is the last stage, which is glaucomatous optic atrophy. So when a patient comes to you with the glaucomatous optic atrophy, we really can't help him out. So that's why when a patient of glaucoma is diagnosed at an early stage, so we tell the patient to please continue drops for lifelong. That is the medical treatment, and surgically if we give an option for it if it is necessary for the patient. But the drops are very important because this has to be continued lifelong, because once the patient is reached in the glaucomatous optic atrophy stage, we really can't help him out. So this is why glaucoma, it is considered as a very dangerous thing. It's a painless loss of vision. So when optic atrophy is there, there is no treatment of optic atrophy as such at present. Okay, so these are again showing the changes of the glaucomatous changes. Okay, so this is a typical picture of glaucomatous optic atrophy, which you can see there is a little bit of scarring also, if you can see in the right side of the disc, and you can see the CD ratio is almost 0.7 to 0.9. so it is there is very little space. The space of the neuroretinal rim is it's very little left, so it is almost reached to the optic atrophy. So this kind of patient we really can't help out. Okay, so next we come is the visual field defects. So this depends upon the distribution of the retinal nerve fibers. So we have the papillomacular bundle, we have the arcuate fibers. Then in the arcuate fibers we have the superior arcuate fibers, we have the inferior arcuate fibers, then we have the radiating fibers. So in radiating also we have the superior radiating fibers, we have the inferior radiating fibers. So the arrangement of the nerve fibers within the optic nerve, that is the arcuate fibers, occupy the temporal portion of the disc and are the most susceptible to damage. So this part is, it's likely to get damaged early. So you need to remember this. So this is the distribution of the retinal nerve fibers. So you need to understand about the arcuate fibers, you need to understand about the radiating fibers also. Okay, this is something about the nomenclature of the glaucomatous field defects, right? So as I told you, there are various, visual field defects. This you need to go in detail, but you just need to know कि there is bearing of the blind spot, there is isoptic contraction, there is arcuate scotoma, and we have the ring scotoma. Then we have advanced glaucomatous field defects. Then we have the sedal scotoma, so that is a paracentral scotoma which joins the blind spot to form a sickle shaped scotoma. Then we have the wing shaped paracentral scotoma. So these are the scotomas, these are the defect, when we see a patient of glaucoma, when we tell them to do perimetry. So it is usually 30-2, which is usually done in glaucoma patients. So if the patient is having glaucoma and is having a field defect, then we see these type of defects in the perimetry. So then we come to know whether it is a ring scotoma, whether it's a peripheral defect, arcuate, sedals. So these are the name of the scotoma depending upon their location, right? So this you need not need to go in detail at your stage. Okay, so this is again criteria to diagnose the glaucomatous field defects. So this is again not so important for you all. As I told you, we need to do visual field test of this perimetry. So this is again 30-2, so which is very sensitive for the glaucoma patients. So this is again the assessing visual field defects. So this is I was talking about. This is the perimetry test report, so which comes like this, which you can see on the slide. So with this, we diagnose it, like what kind of problem the patient is having. So as you can see, the last part, so it is kind of a hollow part. I hope you all can identify a hollow part in this perimetry report. So this hollow part, it's basically a tunnel vision. So this is usually seen in glaucoma patients. So this is really known as the tunnel kind of vision. So the peripheral, all the patient vision is gone, only the central part of the vision is there. So the patient is in danger, right? So this is something very important. You can see there is only a small tunnel vision in the center part. So all other part the vision is gone. So this is a typical perimetry report. Okay, now we come to the investigation. So investigation, there are a lot of investigations for glaucoma. So it's not very easy to diagnose any patient of glaucoma because there can be a physiological cupping also. And in myopia also, sometimes when we come across seeing the patients, we dilate the fundus, and when we check, so there are many patients which have a physiological cupping of 0.3 to 0.4. So that is, we can't label them as glaucoma unless and until we check the other investigations, right? So first we have the tonometry. Nowadays, before we were using Shiort's tonometer. So because of the inaccuracy, or nowadays we have shifted to applanation tonometer, which is usually attached to the slit lamp. I hope you all have seen at least once, or if not, when you all come back, then you can have a look at it. So we have the applanation tonometry, which is a more accurate method. So in that we see the Myers, so we need to match the Myers. So the normal range is again 10 to 20, so 10 to 18, and anything above 18 is suspicious. So then we have the central corneal thickness, we have the diurnal variation, we have gonioscopy. Gonioscopy is again, is used under slit lamp only. So we check the angle. So basically the angle of the anterior chamber is seen with the help of the gonioscopy. Then we have the documentation of the optic disc changes. As I have told you, when the patient comes, we dilate the fundus, we check for the optic disc cupping. So if the cupping is, 0.3, then we have a look 0.4. Then with after 6 months again we call the patient, and then we see if the cupping is, the cup is getting enlarged. So if it is getting enlarged 0.3 to 0.5 and 0.6, then we can label the patient as glaucoma and can start the treatment immediately, right? Because once the patient is reaching the atrophy stage, we really can't help him out. Okay, so then we have the slit lamp examination of the anterior segment. Then, as I've told you, we have perimetry to detect the visual field defects, so 30-2. Then nowadays we are having the nerve fiber layer analyzer. Then we have the provocative test, water drinking test. Okay, so this, as I have told you, intraocular pressure is usually measured with the help of a tonometer. So this, you can see a pictures of Shiot's tonometer, right? And then we have the Perkins handheld applanation tonometer. So this is Perkins. So okay, so then we have the indentation tonometry, which is Shiot's. Then we have the applanation tonometry. So in that applanation we have the Goldman, we have the Perkins, we have the pneumatic, we have a pulsar, then we have tonopen, right? So these are a little bit of they are the instrument which have accuracy, and we can rely on them. Indentation, we really can't rely on them, because the thing is, when we use Shiot's, the patient sometimes squeezes the eyes, then we get a different kind of reading. So we really can't rely on that. So nowadays the best choice is applanation tonometry. So this is, again, you can see in the pictures, as I was telling you, there are Myers. We need to match the Myers. You need to keep in mind the end point of the applanation tonometer. It should not be too small, too large an end point, right? You need to match it exactly, like you can see in the picture. So this is again a lady, sitting, and that is the applanation tonometer, which is attached in the slit lamp, as you all can see. Then in the left side we have the Shiot's tonometry, which is not used nowadays. Okay, gonioscopy. Gonioscopy is a technique, it's a biomicroscopic examination of the angle of the anterior chamber using a gonio lens. So we basically see the angles of the anterior structure from behind forward, like first the root of iris, then we have the ciliary body band, then we have scleral spur, we have trabecular meshwork, and we have shawl base line. So this is usually seen with the help of gonioscopy lens, right? So you all just need to know what is gonioscopy. You all just need to know what is the definition of gonioscopy and what are the structures usually seen through the gonioscopy. Nobody is going to tell you all at this stage to show how it is done or something like that. So at your stage you just need to know that this is a lens which is used to see the angle of the anterior chamber. That is all. So this is, again, you can see like this. You can see the ciliary body, scleral spur, trabeculum, small base line, right? So this is again the structure which you can identify, like when the angles are closed or whether the angles are open. So this is usually seen with the help of the gonio lenses. Then we have the perimetry. So before we were using this kind of manual perimetry. So in that we have the confrontation method, we have the Lisieux perimeter, we have the scotometry, we have the Goldman's perimeter, right? So this you can see the Jerem screen, you can see the Goldman perimeter, you can see the Lisieux perimeter. So this was usually done sometimes before, right? but nowadays, what is usually used is the Humphreys field analyzer, that is basically an automated perimeter. So that is a computer assisted thing, right? So it is more accurate and more reliable as compared to the previous methods. So the commonly used automated perimeters are Octopus Field Master and Humphrey Field Analyzer, which I have seen nowadays. The Humphrey Field Analyzer is more reliable. So the advantages of the automated perimetry over manual. So what are the advantages? So the advantage basically is the interpretation of the automated is, it's more accurate. So that is one basic important. Then we have the automated perimeter variables. So this you don't need to go in detail about the variables and the testing strategies and the programs, right? At this level, you just need to know we use a perimeter, Humphrey perimeter of 30-2. That is all. Okay, this is again, I was talking about the Humphrey field analyzer. So this is grouped according to the central field defect, peripheral field defect, specialty test, and we have the custom test. So it's 30-2, 24-2, 10-2, and macular test. So basically for glaucoma we do 30-2, and that is all. For glaucoma only 30-2. Evaluation of the Humphreys single field printout. This again is is the thing to understand the report of the perimetry. As I've told you, okay, this is the report of the perimetry. So at this stage you don't need to know about the parameters and how to diagnose the perimetry and all. This is PG level thing. So right now I don't think you all need to know this. You all just need to know this is the perimetry report. That's all. Okay, so diagnosis of the primary open angle glaucoma is like when the intraocular pressure raises below 21, and it is associated with the glaucomatous optic cup and the visual field changes. So when all these three things are there, then we label the patient as primary open angle glaucoma. Okay, so with that we have again a condition called ocular hypertension or the glaucoma suspect. So the ocular hypertension is when the patient is having an IOP constantly more than 21 mmHg but no optic disc cupping or visual field changes. So if the IOP is raised only with no optic disc changes and with no visual field changes, then we label the patient as ocular hypertension. And when all the three things are present, then we label as that primary open angle glaucoma. So this is very important, you need to understand. Then we have the other things like normal tension glaucoma. So this is also called low tension glaucoma. So this is diagnosed when typically glaucomatous disc cupping is there with or without visual field changes and is associated with an intraocular pressure below 21. So in this normal tension glaucoma, we have the intraocular pressure is usually normal, but there is a glaucomatous disc cupping. So this disc cupping can be with visual field defect or without visual field defect. So you need to understand if the pressure is normal and there is incidental finding like you have a disc cupping, and then to confirm you need to do a perimetry, and if the perimetry is also normal and the pressure is also normal and you have the glaucomatous disc cupping, so we can label the patient as normal tension glaucoma, but not on the first sitting. You have to call the patient again and again after 2 months, 3 months, 6 months follow-up, and still the pressure is normal and there is no visual field changes, then you can label the patient as normal tension glaucoma. So as the name applies, it is like the tension is normal, the intraocular pressure is normal. So you need to know the three parts. First is the primary open angle glaucoma, in which all the three criteria are fulfilled. Then we have the second is ocular hypertension. So in ocular hypertension we have the intraocular pressure more than 21, right, with no optic disc or visual field changes. So it is only the pressure changes, so quite obvious it is glaucoma suspect and it ocular hypertension. And when the pressure is normal and it's just the cupping disc which you can see, so that is a normal tension glaucoma. I hope these three things are clear. Okay, this is again a picture showing of ocular hypertension, right? So this is the typical disc changes and field changes. So this is the triad of the abnormalities: the disc, the field, and the IOP for diagnosing the glaucoma. So these are the three important things which you need to remember. Okay, so the management part. Uh, okay, so we have the medical treatment, we have the surgical treatment, right? Yeah, so we have the medical therapy, we have the surgical therapy, then we have the organ of the diet, laser trabeculoplasty, and the filtrations surgery, so which is there in the surgical part, right? So the initial therapy of the primary open angle glaucoma is still medical, right? So when it is not controlled medically, then we go for the surgical part. So the basic principle of the medical therapy of primary open angle glaucoma is we identify the target pressure. The treatment regimes are basically a single drug therapy. One topically instilled anti-glaucoma drug is chosen after considering the medical history and the socio-economic background, right? Then we have the combination therapy. If one drug is insufficient to control, then we combine it with another drug. So monitoring of the therapy by disc changes and the field changes is again an initial essential part on regular follow-ups. Okay, so we have the anti-glaucoma drugs. Classification is basically, they have the parasympathomimetic drugs, which is the myotics. We have the sympathomimetic drugs. We have the beta blockers. We have carbonic anhydrase inhibitors. We have hyperosmotic agents. We have prostaglandins. Then we have the calcium channel blockers. Okay, so this is again the same thing. The classifications of the drugs. Side effects is generally, systemic. We have upper respiratory tract symptoms, flu-like symptoms. We have headache, sometimes migraine. Then we have the muscle and the joint pains, skin rashes. Ocular side effects can be conjunctival hyperemia, foreign body sensation, thickening hyperpigmentation, iris hyperpigmentation, anterior uveitis, or it can be a CME, a cystoid macular edema sometimes, right? Okay, so now this is the detailed part of the management of primary open angle glaucoma. As it is already 12, so I think this I will continue in the next class, right? Because already today we were around 10, 15, 20 minutes late because of technical issue. So this I think I will continue in the next class, and till then just you all can have a recap, and I hope the assignments are over for all the students. So when you come back, you need to bring your assignments, right? So so for today I think this is it. Next class I'll continue with this beta adrenergic agonist, because primary open angle glaucoma is generally a long topic, so we cannot cover in one class. So I'll take it in next class, right? So till then, just take care of yourself, stay safe, okay?